Hello doctors, today our topic is fluid control and soft tissue management. First important thing that we need to know is why do we need to control the fluid, and soft tissue management exactly means what. So taking an introduction to this topic, that why is fluid control important. Now fluid control is important for patients' comfort and safety. It is also important for the operator or the dentist access, because accessibility to the particular tooth where we are working is very important. So to for access and clear visibility for the dentist and also for the patient's comfort. Now why is soft tissue management or gingiva must be displaced for? Now displacement of the gingiva is done for complete impressions or completion of a preparation as well, because we do not want our gingiva to get hurt. Number one. Number two is we cannot compromise with the biological width of the gingiva. So we need to take care of the soft tissue which is present and manage accordingly. So now the first important thing is fluid control. How are we supposed to do that during our preparation? And depending upon the task, depending upon the step that we are doing, everything is going to change and vary. What are the options do we have? Now rubber dam, which is also the gold standard for fluid control for a dentist as well as for the patient access, is because a rubber dam will isolate that particular tooth which we are working with, and that will give a direct accessibility only onto the tooth, because it will also remove the distraction of other 31 teeth present, and one teeth that we are working with will be only on the top of the rubber dam. Now placement of rubber dam at times become very tasky and difficult task. Now it becomes tacky, reason being our usage to rubber dam is less. So placement becomes little time taking, as well as that particular rubber dam which when we are placing into the patient becomes tacky for the patients as well. Once the patient and the dentist both are used to with the rubber dam, that's like the best thing to control the fluid, because now fluid is over. Second, only one tooth which we have to work with is on the top. So both the advantages with rubber dam. Coming to the next, there is a high volume vacuum, that is during impression making procedures that is not feasible. Very frankly, that is only for the time when we are preparing the teeth as a prosthodontist, or when we are doing other procedure like endodontic procedures and all. For that case, this kind of, or any surgical procedures in dentistry, in those cases high volume vacuum is useful. For prosthodontists, is not much important. Saliva ejector can be utilized effectively by a dentist himself. Like for example, contradictory statement here is high volume vacuum cannot be used by a dentist. You need to have assistant who has to hold that. Whereas a saliva ejector, you can see it can be placed in the corner of the mouth, placed and opposite to the quadrant where we are working. You can ask the patient to tilt on that side so that the saliva and other water which is coming out from the aerator as well will flow to that particular side, and the ejection of the saliva will take place. Tongue control may be less than ideal. However, if you have to go for tongue control and fluid control both, you have another thing called sweet optor. Now this mandibular tori preclude its use, can trigger gag reflex, because you can see here this part is the tongue retruder. This retrudes the tongue, and this is the saliva ejector which will take over the saliva and eject it out. Now this particular entire such a big instrument inside the mouth can of course give you gag. So that is one where the patient can get gag. Now coming to anti-Salagogues. Now anti-Salagogues are those medications which will not allow the saliva flow to be more, or it reduces the saliva flow. Now there are two main important anti-Salagogues that we should be knowing as a prosthodontist or an oral surgeon or a dentist per se, is methylene bromine and propylene bromide. Now which is to be used when? Methylene bromide is 50 milligram tablet that has to be used before the surgery, or it is 1 hour before any appointment that you're giving. Whereas a propylene bromide, that is 7.5 mg to it comes to around 1.5 or 15 milligram tablets, that has to be again used 1 hour before the appointment. Now the difference between these two is that the onset of action takes 5 to 10 minutes for as a methylene bromide, whereas a propylene bromide. Methylmalonate bromide has to be taken 1 hour before. Now the dosage 15 milligram. Whereas a propanthelene bromide you can give a 7.5 milligrams. So what does that mean? That means that this particular drug has a more faster onset of action. Right? With a smaller dose also work is happening. But till what time? Duration of the action will be 1 hour. Maximum 1.5 hours. Contraindication whereall we cannot give hypersensitive patients to these particular drugs are not supposed to be given. The patients of obstructive conditions of GIT or glaucoma are not supposed to be given. One more thing which is not mentioned here is asthmatic patients are also supposed to be not provided with anti-Salagogue medicines. Coming to finish line exposure, as a prosthodontist, for us fluid control is moreover as a finish line exposure. That why do we need a finish line exposure? So that when we have given a supragingival margin, we do not require that. When we have given a subgingival margin, we have gone 0.5 mm below the CJ, cemento-enamel junction, or we have gone near about 2 mm above the biological width from the alveolar bone below the gingival crevice. In those cases, I need to remove the crevice and then make the impression because my finish line is way beyond down the cemento-enamel junction. So those are the different. For that you require finish line exposure, and for that you have different methods and techniques. So the different techniques are mechanical, chemomechanical, surgical. Let's see mechanical techniques. Rubber dam, again as the gold standard says, not the second option, it should be the first option always, that is a rubber dam. Second is copper band. This was a technique discovered in years back. What they used to do is they had a small cylindrical kind of band. Now those cylindrical kind of thing goes and sits over that particular tooth only. Now very important to note, this copper band technique can be only, see here there is down, this is a copper band. Now this copper band, what we used to do, now this can be used only for single impression. It cannot be used for multiple. Now this particular band which fits into one particular tooth, so it is like this hollow cylindrical thing, it goes and fits into the tooth. When you are fitting into the tooth, what you do is you put some material in that. Nowadays we put medium body. Earlier they used to put zinc oxide eugenol, and on the top or impression compound for that matter, and on the top they used to fix it or close it with help of green stick compound, medium fusing or low fusing impression compound. Now that low fusing impression compound will press the gingiva down. Now here in this area we will put the green stick, that is a low fusing, and on the top we will put it and block it with impression compound. So that green stick will go and press the gingiva. The gingiva will get dilated, will get elaborated, and the finish line will be exposed. This is how earlier days they used to do. Now also we use copper dam. Now copper band is used how? The material inside now you are using is light body, and on the top we are using is medium body. So the difference in the material has come, technique remains the same. Plain cotton cord. Now this plain cotton cord is a nothing but a different name for retraction cord. Now retraction cord can be plain, it can different types of retraction will come over in the lecture. We'll see what are the different kind of retraction cord that is available to us. What are the chemomechanical techniques? Now chemomechanical, as the name itself suggests, we had mechanical techniques. So when you will apply some chemical onto these techniques, that will be called chemomechanical technique. Now what are the chemicals that you can apply to these? Previously what were used were sulfuric acid. They were using trichloroacetic acid. They had even used negatol or zinc chloride in earlier stages. But now, since studies have come over, and now we have some standard elements and chemicals that are we supposed to use with the retraction cord. Retraction cord are mechanical. A chemical used with that, chemomechanical. So what are the now chemicals that we use? We use 8% racemic. See, that is called epinephrine 8%. It is not directly epinephrine, it is 8% racemic epinephrine. The name is racemic epinephrine. Aluminium chloride, we use alum, we have 3% ferric sulfate, 8 to 10% aluminium sulfate is there. Aluminium chloride is around 3% we can use, and alum of course. So these are different percentages are given according to the FDA, and according to that we can use the chemical onto the retraction cord and then retract our finish lines. Now, do you think that these material is different? 8% epinephrine is there, 3% I'm saying ferric sulfate, around 10% is aluminum chloride, and aluminum sulfate is near about 15%. Okay, so these percentages are varying. Now these percentages are varying, time will also vary? Yes, time will also vary, we'll come to that. So this is a viscostat clear 25% aluminum chloride. You can see 25% aluminum chloride is used, and we have, these are the retraction cord. This is available in different sizes, that is 000, 00, 0, 0, 0, 1, 2. These are the sizes that is available. Now what is 000, 00, 0, 1, 2? Which is small, which is big? Where to use? 000, least size, okay? 2, bigger in size. So from smaller to bigger it goes. Where do we use smaller ones? Where retraction is little difficult. Number 1, where the gingiva is tightly adhered to the tooth. Which is that area? Anteriors. Number 2, posteriors, where the gingiva is also very loosely adhered to the tooth, and you can also fix it down. You can go ahead with a heavier retraction cords. That is a number 1, number 2. Now how do we put this retraction cord into the tooth? The instrument that you use to put the retraction cord into the tooth is also called cord packer, discovered by a scientist named Fisher. So it is also advocated by his name, called as Fisher's cord packer. You can see the diagram which is shown here is the Fisher's cord packer. Now this Fisher's cord packer has 2 ends. One on to going to the left hand side, one to the right hand side. It has a round end. Why do we have a round end? So that if you had a sharp end, it will go and hit into the gingiva. Now once this particular round end goes, how are we supposed to keep it with the tooth? Now if our tooth is like this, I am not supposed to keep my instrument straight like this. It has to go in an angulation so that it is not hurting the gingiva down. Now when I put my cord like this, so it is going to dilate that particular area of gingiva. If I was supposed to put it straight down, so what will happen? I will hamper with the biological width. Also, I will deepen the sulcus and I will not retract the gingiva in that area. So this is what is used. Requirements for a gingival retraction material. Effectiveness of gingival displacement should be there. And most important, after displacement has happened, the gingiva should come back to its position. It should not hurt. It should not create any, cuts to the gingiva, absence of irreversible damage to the gingiva. Effective in gingival hemostasis, because what is happening in this kind of condition is there is too much of blood which is coming over. We need to even control that. That was the reason in chemical we used 8% epinephrine. Racemic epinephrine is also a vasoconstrictor when you use it in a smaller amount. So that is the reason we are using 8% in concentration. Should not produce outward systemic effects, like outward systemic effect as in that particular chemical that you are using should not go into the system, blood, and cause any other detrimental effect to any other organ. So types of retraction cord, as I told you, we will come across this. There are 3 different types: twisted, braided, or knitted. Now what is knitted? The first one is not twisted. This is knitted kind of. Knitted is where you put a knot. Knot, the word from knot comes as knitted. So once you have a knot, that is knitted kind. What is braided means? Now braided means whichever have, like our fingers, they have like cuts. So a retraction cord, when they will have little cuts in the particular cord, that will be called braided. And what is knitted? Knitted means all are mixed together, one after another is rolled off. See the last picture. This is a type of knitted kind of retraction cord. So retraction of gingival tissue, gingival retraction permits completion of the preparation. Now first important question here supposed to ask to you is, where and when should we use retraction cord? During the preparation, while impression making, while crown cementation, when? Not during the preparation. It can be and should be used when number 1 impression making and number 2 crown cementation. Cementation procedure and impression making both requires retraction of the gingiva. Very importantly, so it is written, let's see what is written: completion of the preparation to make the complete impression and cementation of the restoration. These are the 3 important things where we need to use the retraction cord. Now importance of finish line exposure. Why do we want our finish line to be exposed? Now finish line which is subgingival, we do not want our supragingival finish lines to be exposed, those are already exposed. The subgingival finish line, if we do not expose and then make an impression, what will happen? The impression material will record the gingiva which is on the top of the subgingival margin. So the crown that will be made will be shorter in height because the margin is here, the gingiva was here. Now the impression which was made of the gingiva, not till the finish line. So the crown which will be made till here, this gap from this area to this area which is not recorded will have caries, will have calculus, will have oral hygiene compromisation with a microorganism embedding into that particular area. Just not microorganism, just saliva also can also lead to sensitivity because at times there can be vital teeth. So we have exposed a part of dentine with dentinal tubules out in the structure in cemento-enamel junction or maybe below that where it is more sensitive. So hence we are increasing the sensitivity of the patient as well. So this is the importance of finish line exposure. Coming to chemico-mechanical methods of gingival retraction. So this was the method which we were talking till now all about, was chemico-mechanical method of gingival retraction. One thing which we missed out till now with the discussion is how much time are we supposed to keep and how are we supposed to pack the cord. I told you the direction how we are supposed to pack. Now for the packing of the cord, may this be the tooth. For the tooth, start from any one end. It is not required, you have to start with mesial or distal, whichever is comfortable to you, but one particular end you start with your cord packing. You pack it simultaneously in one direction, come till the other direction till the end of that where you have started the starting point, and then cut, keeping little of the cord extra. That little cord extra you can just pinch it back or also you can keep it out. After making the impression, while you remove it, you can easy removal of the cord can also take place. Now after placement of the cord and making of impression, how much time are we supposed to give? That is, if I am using, let's go back to some slides before, if I am using 8% epinephrine or I am using may say aluminium chloride 25%, that time 10 minutes is important. If I have to use a 3% ferric sulfate, that time that cannot be kept more than 3 minutes. Now what is the reason for that? Ferric sulfate 3% is more enough to cause hemostasis? No, it will burn that particular area. It will burn the gingiva in that particular area if it is kept more than 3%. So that is the reason after 3% it has to be removed off. And 8% epinephrine is where fair enough and it has caused good vasoconstriction and there is no effect of blackening of the gingiva or damaging of the gingiva, so you can keep it for 10 minutes. Because if you not keep it for 10 minutes, the dilation of the gingiva will also not happen. For the dilation of gingiva, it requires some time. Ferric sulfate is fast acting, so it requires only 3 minutes. So hence I told you every chemical that is used have different kind of reaction and time that has to be kept. So the chemicals used are 8% racemic epinephrine, which I was talking till now, aluminium chloride, alum. Alum is what? Aluminium potassium sulfate is also known as alum. That is a small short term which we use. Aluminium sulfate and ferric sulfate, all with a percentage. Aluminium chloride 25%, 3% ferric sulfate, 8% epinephrine, racemic epinephrine. Ideal requirements for chemical used with a gingival retraction cord. Now what are the ideal requirements? I told you it should cause hemostasis, number 1. Number 2, retraction of the gingiva, it should cause. Number 3, after the material is removed, that the gingiva should come back to its original position. They should not cause any harm to the gingiva, and easy placement of the cord is also important. So these are the ideal requirements for the chemical used with it, and most important, these chemicals should not cause any systemic disorder or detrimental effect on any systemic organ of the human body. Contraindications for epinephrine. Where all epinephrine cannot be used? Epinephrine cannot be used in those cases where in the surgery or in general dentistry we cannot use a local anesthesia with epinephrine. What are those places? A patient having cardiovascular diseases, a patient who is diabetic, hyperparathyroid patients or hypertensive patient, or who are very much known to an allergy of epinephrine should not be given epinephrine. Other than that, other materials can be used. We have aluminium chloride, we have ferric chloride, we can use all those materials. newer materials which have come now in the market, which are used instead of, because this cord packing gets little tacky and again difficult for the dentist. So we have come across different other material, like we have X-Seal, that is a temporary gingival retraction system. We have something called magic foam cord, that is again a polyvinyl silicone. I will tell you what are these materials. X-Seal or a magic foam cord. What you do, see, like we have a syringe, a cartridge like this, and you can see a tip of the syringe. Now this tip is to be touched on one side, like you're packing the cord from mesial to that of again mesial. Similarly, this is to be started from one end without lifting the particular cartridge. This mouth tip should not be lifted from the tooth or the gingiva. It should be placed like this and with a dropping motion like you do for the saline into the root canal. Similar motion you have to go ahead with all the sides of the tooth and then come to the finish line or the starting point. And then basically these materials are nothing but polyvinyl siloxane. These are nothing but, this magic foam is to polyvinyl siloxane addition silicone, and X-Seal is nothing but a condensation silicone. Basically what they do, they just dilate it. But the only problem with X-Seal and magic foam is that they can only give a retraction. They cannot give hemostasis. But it is easier way and effective amount of retraction is also possible with these kind of material. So these are used nowadays in the clinics. Coming to rotary curettage. Now rotary curettage was discovered in the year of 1944 in Amsterdam, which says that also it is known as gingitage. The other name for rotary curettage is gingitage. What is that is nothing but simply you cut the gingiva all around the tooth. When you know that the biological width is enough, it is not going to get hampered. First point. Second point, you know very well that the sulcus which is there is not having any pocket more than 3 mm. In those cases what you do is you just take your burr and you cut the gingiva all around. That is also called gingitage. So let's see what are the 3 factors to be considered. Absence of bleeding upon probing, that's what I said. That means there should not be any hampering of the biological width. Sulcus depth less than 3 mm. That means what I said was pocket depth should not be more than 3 mm. Presence of adequate keratinized gingiva. Keratinized gingiva means the supportive gingiva. That is a biological width ka starting length of the gingiva. That is a keratinized gingiva. That should be adequate enough. Why keratinized gingiva is important to us? Because that is a keratinization is important to take over stress. So when there is a crown is going to come over that particular area, that should be able to take over the stress onto the periodontal ligament. So keratinized gingiva is important for us. Non-keratinized is not that important. It is also called as gingitage. It is not mentioned here. Coming to the newest technique in gingival retraction is again electrosurgery. Nowadays it is done with the help of lasers, that is diode laser, or also carbon dioxide lasers are also used in this with a nanometer of 810 nanometers they are used. Now what you do in this is very simple. It is you attach, see, you can see this black pad. This is called earthing pad. This is attached to one of your body structure, maybe your hands or your legs. And this is a machine, which has a tip. They have different tips for hemostasis. They have, they call it boil points. This is mostly used by surgeons, not by a prosthodontist. But yes, it is effective in, most effective. This is not used for, so much it is used for, not used for finish line exposure. But this material or this entire setup is used for pericoronitis patients basically, or the patients for those who we have to go ahead with crown lengthening procedures. That is one more thing we need to talk about when we are talking fluid control and soft tissue management. That is crown lengthening procedure. We'll come to that. So scalpel points are there. We have vertical loops. We have toughening points. Horizontal loop. All different points are available. And with these, the amount of gingiva and the biotype of the gingiva, we have to decide with these kind of tips that we are supposed to use for electrosurgery. Now before ending, I would like to also speak about that how much amount of crown lengthening is required if our crown is short and we have to give a subgingival margin. Crown lengthening is required. Now how much amount of crown lengthening is required and how will we decide that? Crown lengthening procedures are of 2 types. Either it can be a surgical procedure when we have to gutter the bone down and then you have to apically place the gingiva and then suture it back, or else just do a gingi-touch. That is also a way of crown lengthening procedure. But clinical crown, if it is not efficient, the different other techniques that can be hold is number 1, crown lengthening, number 2, orthodontical extrusion of the teeth. The first importance should be given to orthodontics because they use the natural force of the teeth to make it out. So extrusion of the teeth with the help of orthodontic forces will also increase our crown height. Other thing, if nothing is working out, what are we supposed to use? At that time, we will use retention grooves. So in a tooth, if we have a tooth to prepare, for example, this tooth to be prepared, and our crown height is also less, what we will do, we will put multiple retention grooves. No fixed rule that give it only on buccal or lingual, on palatal or mesial distal. Put it multiple roots when it is a single crown and you know that the crown height is not efficient. Patient is not going to go for orthodontic extrusion, or patient is not even going to afford for a crown lengthening procedure or surgery. At times it is contraindicated in many patients. So just put multiple grooves. That kind of preparation is also called bucket preparation in prosthodontics. So that is how we need to, retract the gingiva and make the impression. And also why did I say during the cementation? Because while cementation we are doing, even that time, if our crown is not seated properly, amount of GIC luting or any luting agent that you are going to put is going to stay back down in the area of the sulcus. Now you know very well that first 24 hours our GIC is acidic with a pH of around 2 to 4. So when it is acidic and gingiva it is in contact, so it will burn the gingiva and cause harmful effect to the gingiva. So our purpose of doing the entire retracting the cord and all is again to vain. So hence, even during the cementation, we need to retract the cord and do the cementation. Thank you.